madam. Greetings to all of you, all the learned faculty members here, and all those people who are attending on the webinar platform and YouTube. So this is going to be a talk on cluster endophthalmitis, do's and don'ts. It is not going to be any technical, but we are going to talk about what we should be doing and what we should not be doing. So one thing is some of the images, some examples are from hospitals and net as examples only, nothing against any hospital or person and no financial interest. The doctors were treated as God model even a few decades back, but now we have gone into an era where it is a patient-centered approach. Now today, a person coming to practice after MBBS should be ready to face complications. There is no treatment without a complication, not only surgical, it can be even medical. So people awareness thanks to the net is much more, and they use it and probably misuse it to go against the healthcare system. So it is our mental strength that is needed to face it and come out strongly by certain measures, which was told by Dr. RDR sir and Nirmal, documentation, following protocols. If you have done things properly, but this mob attack and all those things are not at all in our control. Even at this point, nobody can control it. But at the end of the day, legally, we should be coming out strongly. This is something which has come very, very strong now, rights and responsibilities. And most of the cases in the court go with these things in mind. More than 50% of cases in India are lost because of improper consent forms or absent consent forms. This informed consent is not proper, and that is enough to finish the case off, even if you have done everything else properly. This is something which is happening and which should not be happening. When complication occurs, what happened only will be asked, or what did you do will be asked. What did you do or what happened? It is not asked what happened. What did you do is assuming that you made a mistake, which is not good. Professionally also, this is happening between the colleagues. So it should be actually what happened, and then we need to find it. It reflects on the mental attitude of the person who is asking, and it will go a long way against the person's mind who is actually involved. Seeing a cluster endophthalmitis is really a nightmare of nightmares. So by definition, any surgical site infection within 30 days of surgery is a surgical site infection, where endophthalmitis is also one. But when we have an implant inside, it can go up to 90 days. So what are clusters? They say 3 to 5 cases in various books, but as Dr. Saravanan said, even 2 cases considered as a cluster. Even a single case or 2 may be a warning for a cluster to come. Even consecutive day cases will be called as clusters. Indian scenario, though we have seen some reports, clusters are occurring across the India. Many are not reported. Except the big organizations, the smaller people never respond. Very few publications are there. So really do not know actually what is the total scenario across the country. But today we have protocols which has been very nicely elaborated that makes us our infection rate to 1 in 10,000, less than 1 in 10,000. That means what? We have a wonderful protocol. But why do clusters occur? But we have to do 70 to 80 lakh surgeries a year. Camps are there. But when we do mass number of cases, there are some compromises we undertake, and we need to accept when these compromises are undertaken, the sterility can be broken. The sterility breakdown can occur, and that is why these clusters. We must understand one thing, any cluster occurs, it is iatrogenic. It is definitely iatrogenic, and the hospital-acquired infection only it is, not anything endogenous. So where do they occur? It can be a single doctor, small hospital to a regional institute. Nothing is immune to cluster endophthalmitis. The source could be any of these things, starting from the person who's assisting. There was an instance in one of the smaller towns where the assisting nurse had a subclinical throat infection, and series of infections occurred over a period of 4 to 5 days. And then what happened? Everything else was negative. Then the microbiologist with whom we worked took a swab from all the OT staff, and that was sent. It was positive for an organism, and that was sent along with the cultured organism to Italy that point of time, and found out it was a subclinical throat infection which had caused the cluster. So everything is there, and it could be in the OT setup, it could be sterilization devices, personnel. Patient can also be a cause to cause infection and it can spread to others. Of course, the environment we forget, not only inside the OT, surrounding the OT. Every other place is important inside the hospital. What happens now? When a cluster occurs, there is always an internal conflict. And even if we see one endophthalmitis, we know how our heart is going to thump. But when we see a cluster, the people who are operating and the management will definitely panic. It is very important that we don't panic. We have to identify this, and as pointed out beautifully by Dr. RTR sir and Dr. Shivakumar, recall is you have to call every other person and see that you start early treatment, early management, which has been described beautifully earlier on. The findings should be documented. Another important thing is smaller hospitals, when they get 3 cases or 4 cases, they're scared to refer. They don't want it to go public. But that is not the way, because by delaying, we are only making the inevitable of making the patient blind, and the problem could become worse. Without hesitation, it is better to refer them to a higher center where the facilities are available. Informing authorities, according to Blindness Control Society, especially when mass blindness is going to occur or mass infections are occurring, especially with that of camps, including paying cases, you have to report to the District Blindness Control Society. And of course, you have to be very careful when you tackle attenders in cases of cluster endophthalmitis. Some of them can go violent. You may get multiple calls of threatening and so on and so forth. It has to be. So the most important thing I would advise, on day 1 itself, independently talk. Explain to and you also mark it in the case sheet that it has been explained. Even if not during the crisis, legally it will hold a very good value. To find the source and eliminate, prevent further catastrophes, manage, all these things have been dealt with as to how it has to be done by Dr. Lalita and everybody else. Now, when you are going to work up a patient, please do not keep a blind eye. Don't try to prove that there is no problem with the hospital. Try to find out what is the problem, because it has to be 100% in the system only. It may be the consumable, but still we are responsible because we get the consumable and we are doing. As it has been pointed out, there is a batch testing of some consumables which can be done before we put it into use. But we are not talking about that now. The infrastructure, how it is, whether the whole infrastructure of the hospital, the OT, whether it is a very good hospital infection control program, document protocols, and you have to also look for sterilization breakdown and so stuff. See, what happens is there would have been 1 or 2 instances of sterilization breakdown. One indicator is not seen, biological indicator. They just marked it. But 1 or 2 cases of investigation, they found out that this was positive and no proper step was taken. Adia said, it is not important only to do that. Somebody at a higher level who's in charge of the OT or the doctor should monitor these things to prevent a catastrophe like a cluster endophthalmitis. Case sheet is very important. How you document, how you write, especially how you tell the patient and the attendant. Get their signature on day 1. It is easier. On day 4, day 5, we cannot get a signature. Informed consent is a must. But what is happening is some of the hospitals, they do camp surgeries. The informed consent is not as good as that of a paying. So as far as patients are concerned, NABH also tells that paying or free, all are equal. You treat them equally. Investigation scan and photos. Actually, for another case where an investigator had to go and explain the scan to the CBI. So there are all very important findings which will go towards your how you are going to manage a case of cluster. Minimum 2 or 3 times. They see once, they go, and next day they come is not acceptable. This is an emergency. Cluster endophthalmitis itself is an emergency. You have to make entries and expert management if it is available or referral. Everything should be mentioned and then sent. This consent form should be proper, and we are not going to talk about consent forms. There are many things about consent forms. It should be as per, we have so many examples, so many templates that have been distributed across, including at all India level. You have to shut down the OT once a cluster. There is no question of continuing the OT. The problem is when the cluster occurs late, we do not know. But pseudomonas and all can occur within a day or 2. The complete workup, as already mentioned, do not forget the environment and water and all those things. Review all the protocols, validations. So how long will you see all these things is very important, which I will come shortly. When could they become a legal case? Please remember, today every case can become a legal case. And when it comes to endophthalmitis, any endophthalmitis and cluster is definitely illegal. But some of the hospitals can manage to come out of it with proper management, giving them all vision. Some of them go for early settlement. All these things are occurring even now in the country. So what happens? Suddenly one day, 3, 4 people will join together. Nothing they will do. They'll go in front of the hospital and block the road. This is what has happened in a few instances. Or knowing about this, a lawyer will come catch hold of them, will give them all some money and say, I will put a case. Whatever comes, this is the split up. So these things happen and they will run the case. Then what happens? There you may not even know. Somebody will call and say, your name is there in the TV. I'm seeing what is happening. So this is something which is you have to tackle attenders and public at that point of time. Media will be very difficult. You have to be prepared. You cannot avoid the media sometimes. Avoiding also may go against us. Be prepared for an investigation. Sometimes when it comes on TV, in one instance, it came on TV within that same evening. It came at 11, 12. Before evening, 6 o'clock, there were 6 departments that have come. The main group will be the dean or the joint director, the surgeon, and the micro. That is the governmental team. Then the district blindness control or the state blindness control will come. The drug inspector will come and take the relevant drugs. Police, of course, you can be taken to the police station, or they may. Some of them are very decent. They will come and investigate you. Human Rights Commission will also come, and as required by the court, it can be any agency, including the CBI. And what an inspection team will look for is a standard checklist. Now, importantly, it is prospective and retro. Prospective is from the time of occurrence, what all has happened. Retrospective, there could be a question, what is retrospective? We all think from the time of admission till the surgery. Definitely not. In one instance of cluster, they took the consumables, everything for the previous 2 years to see per case are they changing the gloves, to see whether they're changing the needle. So retrospectively, they collected data for 2 years. So anything should be documented. Most important, if everything from our side is good also, license, the Clinical Establishment Act, the Pollution Control Board, any of this is wrong, then the whole thing what you have done will become wrong. So this has to be always in place for any hospital. Environment would be checked, sterilization, autoclave and surveillance validation, medicines, consumables, personnel. In one instance, again I'm telling only based on instances, 70 people were interviewed. 70 people were interviewed. All the people who are doing whatever they are should be very fluent with what they are doing, what to do when there is deviation. They also can investigate with the patient in cases of cluster. So sequential documented evidences only will give us fantastic, positive report about what we are doing. The case record should be good. Everything should be documented. I think it has all been covered. The validations and surveillance, make sure none of this is negative, because that particular time when they come on it, they will find out one small thing 1 week earlier has been missed. That is enough. That is enough for them to go against us legally. These logbooks, who enters and whether all the people are, entering in the logbook, autoclave logbook, flash autoclave, medicine usage for recall, surveillance registers, all are very important. People involved in each of these processes should be very much aware how to take care of all these things, including, maintenance of the equipment, calibrating equipment, everything, AC maintenance, because sometimes the split ACs are still there in many hospitals. Maintenance of that is very important. Even that water leaking from split AC can be a major source for infection. Camps, this is something which sometimes has been a major problem. The permission should be sought for camp. DBCS will either send somebody or would have given permission. The camp organizers, patient, all these people were all investigated or inquired during one of the clusters. So everything you have to follow the protocol. How is the hospital affected? We will be closed mostly. It can be closed by the administration, or the hospital itself may shut down. Bad reputation. Sometimes the employee go jobless. There are some hospitals which have suffered for years. And the comeback is not going to be from zero again. It is going to be from -20 with sometimes a bad name coming. Surgeons have been threatened, have been assaulted. it is the people of co-professionals, our other patients, family who should give strength. It is a very difficult, traumatizing experience to face this situation. We have to come out of it. This is in one particular instance, wrong surgery performed, caused loss of one organ, forcefully retained the patient. These were that lawyer took this patient, there were 11 of them out of a possible 28, and he put the case as this. And there is something what we must know, protection for doctors to prevent arrest. So there are investigations that will happen by many agencies, case can go for hearing. It is our duty that we are not negligent. It is our duty to prove there is no fault on this is something where we have to prove. This will not come overnight. The protocol should be there. It should have been followed. That will give us. So this Supreme Court order says unless they are inquired by the doctor or doctors qualified in the same branch, and then they say they are negligent or they say they are not negligent, only the action will be taken. If they are negligent only, then the court can give order to take a legal action on the doctor, because they don't want people who are not negligent also to be hurt by this. There is a Supreme Court order. Actually, if the doctor has hit somebody or something, then that becomes a criminal case. For medical purposes, nobody can be touched. This is something which every doctor in our country should know. What are the protocols we need to follow? So do we need to have NABH all the time? Not necessarily, but you need to follow protocols that are peer reviewed and which you have evidences that these protocols are good. So we have guidelines from AOS also, the second edition and so on and so forth. But here we need to agree that there are some amount of compromises to make sure that we do more surgeries, especially camp surgeries. But ideally, I would say the NABH will only give importance to only approved protocols. So at least the entry level, that is what the Insurance Regulatory Board will say. Entry level is mandatory. So minimal requirement, if you say, and that too NABH is being part of the Ministry of Commerce, it will have a lot of value in the court of law. We really offer very high standards of surgical skills to our patient, but we fall prey to infections because sometimes there are compromises at different levels patients where the people may not realize what is the major problem that is going to come at the catastrophe. So maybe at a lower level, the person who is cleaning or something like that, so we may end up. So ultimately at this point in time, we need to say, whatever happens, there may be 50 people involved, but it is the surgeon only, because it is our duty to make sure that your tray has got an indicator which the color has changed or something like that. So this is something which has already been told. Document means you should have a protocol. If the protocol for that is not there, it is not done. If it is not recorded, it has not been done. This is only going to save us, and it should be consistently done regularly. So before surgery, case sheet workup, to summarize, systemic workup and informed consent. All this is very important. Then you need to have a retrospectively record of surveillance, record of consumables, and eliminate source if at all there is a problem which has occurred earlier, and prospectively patient management, documentation, referral if necessary, workup, and eliminate source. So these things are important. Now you must ask me one question. You have been telling only what to do. Important don't anything. Can anybody say? Don't forget to do any of these things. And most important message of a don't is, don't try to alter the case sheet or any of the evidences, because there may be always a chance that all these things would have been given as a copy to the person who is going to be affected. So that will go totally against, and even if you have done 100% things correctly, it will not help us. Do not try to tamper any of the records. That is very important. There are many of us, every doctor works, but the problem is, unless we review ourselves, update ourselves and improve, we will not, our dream is to have a 0% incident, but we are nearing, 0.0, we are going into 2 decimals and 3 and so on. It is good. Whether it's a dream or reality, we really don't know, but still we need to know that this endophthalmitis can occur, and there is also a good chance of cluster occurring even if we fail. Are we justified in sharing all these things, apron, gloves, tray, phaco, microscope? Now we have wonderful protocols to use it again, but in between sterilization process should be good. In between cleaning process should be good. Gone are those days, where we can start with one and finish 100 cases. But now these protocols should be done, but we cannot share certain things. Ultimately, whether it is one patient or a cluster of patients, we do not have an endophthalmitis. So cluster endophthalmitis, there is no immunity to any hospital or any doctor. So once it occurs, they have to be all the more careful not to get again. So this is something, we don't have failures. Your failures do not define you, but it can definitely step up your vigilance and your efforts and everything to prevent endophthalmitis and cluster. Thank you so much for your patient hearing.